So the final installment on glaucoma, this is on management of glaucoma, and again it is for optometrists. The goals is to cover the treatment of glaucoma. It looks at the range of drugs that we can use. It will discuss compliance issues, but primarily look at the NICE guidelines for glaucoma which guide our management strategies, and it will also cover some options available if medical management fails or if the patient is non-compliant. So in Britain, our primary template for management strategies is the NICE guidelines. The first one came out in 2009, and then we've had an update in 2017. But the two go hand in hand. Who are they meant for? Well, it says it's for all healthcare professionals, obviously including optometrists, and also for commissioners and providers of eye care services. So anyone who's coming up with a new service for GAT refinement or stable glaucoma management or whatever will certainly use the NICE guidelines as its template because it's evidence-based. Before we consider the 2017 guidelines in detail, I think you have to look at the provenance of this 17 document. To me, it definitely evolved from how particularly optometrists interpreted the 2009 guidelines. Now, the 2009 guidelines were, in my opinion, very comprehensive, and they really were trying to improve glaucoma management at every level. But it would appear that our profession did not necessarily interpret it in the spirit in which it was intended, and indeed a certain proportion of our profession, in fact, it allowed them almost to abdicate all responsibility and basically state, well, pressure's over 21, NICE state refer, which they didn't really do, but we've interpreted that way, and I think it has damaged us to some extent. So the 2017 is a good reflection of how we've performed over the previous 8 years. It was far more prescriptive. It is far more prescriptive, and we'll go through some of the things it states. Now, optometrists, and that's all of us, whether we've been qualified for 1 year or whether we've been IP optometrists for 10 years, we are classified as case finders. That's all primary eye care professionals. And what the NICE guidelines state is, before referral for further investigation and diagnosis of COAG and related conditions, offer all of the following tests. Now, I take real issue at the term diagnosis. It is saying that we can't diagnose glaucoma. Now, I fully acknowledge that we're not supposed to be therapists, but I actually believe, particularly IP optometrists, we are extraordinarily good diagnosticians. And I will debate that point. It also states that, well, what we're supposed to do is we've got to offer central visual field assessment. We're allowed as mere case finders to use either a full threshold if we want to, or just a super threshold. Now, as I've said in earlier talks, super thresholds for us are out. For instance, the reason they say we're allowed to use super thresholds is because they state within community, glaucoma is rare. The majority of patients we see are normal. So they're saying a super threshold as a screening protocol is going to be more appropriate. Well, if you've done a thorough case history, followed by tonometry, followed by pachymetry, and Van Herrick and anterior chamber assessment for any secondary signs of glaucoma, and then you've done an optic nerve assessment and you've found something that's suspicious, then you're no longer looking at a normal population. You're looking at a human being who you're extremely suspicious has pathology. So we have sieved down the possibilities that this is a normal patient, and we are extremely suspicious that this patient is not normal. And so therefore you have to have a field assessment strategy that reflects your suspicions. And patently that would require a thresholding field. But onward they go. We then have to do it. Obviously we have to do an optic nerve assessment with Volk. We have to do a peripheral anterior chamber configuration assessment in some form, probably, or at least in my case, Van Herrick or OCT. And again, in brackets there's 2017. So they've specifically written that in because they're telling us that we have to do these extra things now. This was not included in the 2009 one, but because of the way we've performed, they have actually qualified it. And as I said, been quite prescriptive about it. And then we have to do IOP measurement using GAT. And they, again, in 2017, specifically said, do not base a decision to refer solely on IOP measurement using non-contact tonometry. So again, very much a reflection of how we performed as a profession between 2009 and 2017. So NICE go on to say, do not refer people who have previously been discharged from the hospital after assessment for COAG, unless there's a change in circumstances and a new referral is needed, 2017. And I do think this is an ongoing problem for optometry. There's a lot of optometrists out there being forced to do particularly fast sight tests to get more people through and dispense more glasses. There's also a growing population of locums who, may see a patient once and possibly will never see that patient again. So it's easy just to take that one episode and say, oh my God, CD ratio 0.8 must be referred. Because these people haven't got perhaps the time or perhaps the inclination to accrue all the information, past history and so on, and realise that the patient's been referred several times previously for the same thing, has been discharged from the hospital, and nothing about the situation's changed. The optic nerve looks exactly the same, the fields are the same, the pressures are the same. So in those circumstances, there's actually no rational reason to re-refer the patient. Before deciding to refer, consider repeating visual field assessment and IOP measurements on another occasion to confirm things, unless clinical circumstances indicate urgent or emergency referral is needed. But I will put in the caveat, or if your diagnosis is ironclad. And I did say diagnosis, and I'll give you an example of this later. So obviously, if the fields is just this spurious field that it doesn't really correlate to anything you've found, then for sure you need to repeat it to find out if it's real or not. But if it correlates with everything else, then there's probably no real reason to repeat it if you know all the jigsaw pieces fit together. But I'll show you this example later. And refer for further investigation and diagnosis of COAG after considering these things. Is there optic nerve head damage that perhaps correlates to glaucoma? I'll stick in. Is there a visual field defect consistent with glaucoma? And I'll stick in and correlates to the optic nerve damage you've just seen. Is IOP higher than 24 using GAT, repeatable 2017? Now, I don't know how NICE define diagnosis, but if a diagnosis is based on your best hypothesis and all the jigsaw pieces have tied together, you are referring very strongly of suspect glaucoma. You've made a diagnosis. Now, it might be confirmed, but you've still made a diagnosis. And provide results of all examinations of tests with the referral 2017. One would argue that's been stuck in because some people didn't. And I do think after 2009, they were simply precious 25, NICE dictate referral, and they didn't do anything else. There was nothing else the hospital had to work on when they were triaging that letter. And after all of those things we're expected to do now, we're still not expected to measure CCT. I don't understand why. So NICE then go on to describe their stance on the diagnosis and treatment and management of glaucoma. They say that diagnosis of OHT and COAG and the formulation of clinical management plans should be made by a suitably trained healthcare professional with specialist qualification and relevant experience. And I think the relevant experience is very important. I talked to an ophthalmologist once and he said, look, Peter, we see glaucoma patients on an industrial level. And I think if you're doing something like that, you get very, very good. Whereas in the community, we would not manage very many. And therefore, I doubt very much we'd have enough real experience to be at the top of the game. They also then say healthcare professionals involved in the diagnosis of OHT and COEG should be trained in case detection and referral refinement. I believe we are. They should be able to identify abnormalities based on relevant clinical tests and assessments. And again, I believe IPs are. But then they say an independent prescribing qualification in isolation without a specialist qualification dealing with the complexity of glaucoma being managed is insufficient for managing glaucoma and related conditions. And I do completely agree with that. I think it belongs in secondary care. It's chronic, ongoing. I just don't think it really belongs in the community. But then they say, what should a diagnostician be doing when they're assessing a patient? And these are the things they list through: medical and ocular case history, differential diagnosis, GAT, threshold perimetry, a stereoscopic look at the anterior chamber for secondary etiologies, examination of the posterior segment using a Volk, gonioscopy, Van Herrick, and CCT measurements. Now, gonioscopy, I admit I'm not very good at. I'm the first to do that. But I don't believe in the community from a diagnostic point of view. It makes that much difference. We've got a lot more technologies now, and I've never felt hampered by not being particularly good at gonioscopy as far as referral goes. Standard automated perimetry, well, certainly I've said banged on for 3 lectures. Threshold, that's what we've got to do, because we are diagnosticians in the community and we want to give the hospital all the information they require. Medical and ocular history, quite frankly, if you can't do a good medical and ocular history, you shouldn't really be an IPer, because it impacts on everything you do, whether it's anterior eye or posterior eye. We need to know what the patient's done before. We need to know what they're allergic to. We need to have a full understanding. And I think IPs are very good at that as well. Differential diagnosis, there can be hiccups, slight hiccups there. The classic one being normal tension glaucoma. We might diagnose it as normal tension glaucoma, but if they're outside the normal demographics, they might decide at the hospital to do an MRI scan in case there's something mimicking that sort of optic nerve damage. Now, that doesn't mean we're bad diagnosticians. A diagnosis is your best hypothesis, and you're going to refer anyway. And at the hospital, that's where they have the MRI machine anyway to make that differential. And, you know, GPs do this. They'll suspect something and say, I'm sending you to the secondary care for an MRI scan. Nothing wrong with that at all. It doesn't make you a bad diagnostician. And secondly, CCT measurements, really important. I don't understand why we don't, all of us do it. I certainly do, and I think it's really important. So anyway, let's get on to these studies now. So as I've said before, prior to the 6 multi-papered longitudinal studies, apart from expert opinion, there was no evidence treating glaucoma actually helped. And as I've already said, that doesn't mean we all had it wrong. We all intuitively knew, but what these studies allow us to do to some extent is not only who to treat, but who not to treat, and indeed how aggressively to treat. And that's really important. So let's go through them now. These are all synopsized in these documents, the European Glaucoma Society documents. And on my website, I have edition 2 and edition 4, and they both add to each other actually. So it's kind of worthwhile browsing through them both, really. So firstly, there was the collaborative normal tension glaucoma study. This is a treatment versus no treatment study. And in the 2014 outcome, they said a beneficial effect of IOP lowering was found. Yay. Now, we probably all expected that, but honestly, prior to these studies, there was a cohort of people who truly believed that treating normal tension glaucoma was not worth it. This is up till very recently. So what they found is that in the treated arm, 12% progressed and 88% survived. So even though they were being treated, 12% progressed, and in the untreated arm, 35% progressed and 65% survived. And they also said that progression rates varied a lot. Now, in the 2003 document, they also confirmed that reducing IOP is beneficial, but they specify that for patients at risk. So there is a little bit of a trick. Who are at risk? And they said a 30% reduction in IOP reduced the rate of visual field progression, but more than 50% of the untreated group had no harmful progression in 5 to 7 years. So they said that IOP does play a role in progression of some normal attention glaucoma patients. And they then postulated that progression, for the people that progressed, progression may not be related to IOP. And secondly, they said perhaps the subjects may not have been at their own personal targets. Now, they can't say that as proof. They can't say that's true. They're simply taking the data that they've found and they're postulating why the outcomes are the way they are. But certainly knowing normal attention glaucoma as we do, there is a high possibility, I think, that isn't related to IOP at all. It may be more vascular. The ocular hypertensive treatment study, they found, again, it was a treatment versus no treatment, after 5 years, so this is in 2003, 4.4% of patients converted to POAG, even though they were being treated, and 9% of untreated patients converted to POAG. So you could read that as saying, by treating everyone, we had a 50% reduction in conversion, which kind of almost sounds good. But of course, 4.4% converted anyway. So 50% reduction only meant a drop from 9% who converted in the untreated group to 4.4%. So it doesn't sound that great. And over 90% of untreated patients didn't convert anyway. So it makes you think, well, who out of that group should we be treating? Because if you treat 100% just to get 4.4%, it seems a bit of overkill. Then in the 14 update, after 13 years, 16% of the treated arm had still converted, and 22% of the untreated had now converted as well. So time will tell sometimes. So for prophylactic treatment, the risk factors to predict conversion, they suggested the strongest was CCT. So again, we have to do CCT because it's the strongest predictor if you've got someone with ocular hypertension. And IOP, obviously, the higher the IOP, if you've got someone with 25, they're not going to convert. Their risk level is much, much lower than someone with 28, obviously. Baseline age, horizontal and vertical CD ratio, and PSD. And the European Glaucoma Prevention Study identified those 5 things, but also found disc hemorrhages to be relevant as well. So out of the document it comes, according to these results, CCT corrected tonometry readings are valuable when IOP measurements are high and treatment is being considered. So again, if we're referring on an intent to treat basis, I think we do need to have a CCT. So the early manifest glaucoma trial, that showed, there's no real surprise here, is there? A 25% reduction in IOP reduced the risk of progression. Risk of progression was smaller with lower baseline IOP, absolutely no surprise there. Risk of progression was lower with a larger initial drop, again, no surprise. Risk of progression was reduced by 10% per every 1 millimeter reduction in IOP, but progression rates varied substantially between individual patients. So again, that's where the art form comes into this. Frequency of disc hemorrhage is high with lower IOP. Yes, we know that. Normal attention glaucoma far more likely to show disc hemorrhages than POAG. And IOP levels did not increase over time in untreated POAG, but did with exfoliation glaucoma. It's interesting that. So you think, right, pressure goes up so far, enough to cause damage, but doesn't seem to go up anymore, which is quite interesting. Anyway, they said the important risk factors in both 2003 and 2014 was higher IOP, exfoliation syndrome, because remember, this is OAG, right? This is all open angle glaucomas. More baseline damage, increased age, disc hemorrhage, thinner CCT, specifically with POAG, and low blood pressure, specifically with NTG, they found. So there we are. There's the three I'm going to go through. The others I'm not going to touch on. These really impact on us in the community. But the bottom line is, of course, all we got is to lower IOP. But that's where the art comes in. Who to treat, who to monitor, who to discharge, and how aggressively to treat. And that is art as much as science. So this is a sort of a who to treat graph, which I think is important to go through, although it doesn't necessarily help you totally on individual patients. If you think that we lose ganglion cells throughout our lives anyway, so there's a gradual decline, that's our normal. And so that's the sort of baseline that you've got to work against. And if you look down here, the black line is severe visual function, the sort of theoretical line we need to keep someone above. Now, whoever defines that, whatever, but that's just a theoretical concept. So patient D here actually has quite a slow rate of progression, and therefore potentially, if you knew what the progression rate is, there's little impact on visual function over their lifetime. So do you even need to treat that patient? The argument, you may not. And they do say in some of these articles and stuff, they say no progression is not necessarily the goal. To reduce progression to a point to not impact on the life, that is the goal. And NICE state that. And so does the European Glaucoma Society. Patient E, of course, has a rapid rate of progression, and obviously you need a much lower target IOP, absolutely essential there. Now, patient B, an older patient, so you can see they weren't picked up till much older, they have a moderate rate of progression, and that's a tougher one in a way. Is it going to impact? Is it going to cross that black line? It depends on the life expectancy, which you can't always predict. And then patient C is a younger patient than B. They actually have the same progression rate as patient B, but of course, because they're much younger, they have much longer time for it to potentially impact on their visual function in their lifetime. So, okay, that's theory, but it does set the ball in motion as to how you might approach these things. But how aggressively IOP should be reduced initially depends on the degree of visual field damage at diagnosis and the risk of progression. Now, many clinicians like to set themselves a target pressure, but how do you do it? What do you base it on? And okay, here's this little diagram, which initially looking at it is a bit naff actually, but it does give you an idea. And it is, if someone comes in with advanced glaucoma because they've never had an eye check or whatever, then patently you're going to hit it with everything. You're probably going to go straight to surgery. If they're very, very young, again, so there's some clear-cut ones. But of course, if a patient you don't always necessarily know the progression. If they're 60 and they've got a little bit of glaucoma, you don't know quite how long they've had it. You don't quite know what the progression rate's going to be. But it gives you an idea. But as a default thing, basically, if it's early to moderate glaucoma, lower it by 20 to 40. If it's advanced glaucoma, 40 to 50%. Once a rate of progression is established, that is to say estimated, then treatment can be adjusted. So initially, when you've first seen that patient, you're having to make some assumptions about their age, about life expectancy, about the state of their glaucoma when you first saw them. But then after that, once you've monitored them for a while, you can give a much more accurate prediction of their progression rates, and then you might modify the treatment. So I want to bring up here now the differential between us in the community diagnosing and progression and monitoring in the hospital. Now, this is the one I was mentioning earlier. This is a patient. She came. Her pressures are only 12 and 10. At this time she was only early 40s. She only came because she was starting to have trouble with the reading. And when we looked inside, I saw this. So the vertical CD is a bit odd anyway, but more importantly than that, you can see that the inferior rim is a bit notched and there's barring of that circumlinear vessel. She also had migraines, she had Raynaud's, she had cholesterol issues. So there are some other medical sides that start to make you think, this lady's at some level of risk. So we did the glaucoma fast threshold on her. This is with a Medmont machine. The pattern deviation was 9.75, highly statistically significant. The cluster analysis, so with Medmont they have a thing called cluster analysis rather than glaucoma hemifield test, but it's the same thing. So it had a superior depression, and I decided to repeat the field. Now really, back to what I was saying before, to me that's a cast iron referral, right? The field loss corresponds perfectly to the inferior notch and barring of a circumlinear vessel, but I decided to repeat anyway just to confirm it. And that was 24 hours later. That's the new field. Now that shows a learning process. She still had a pattern defect. It was still statistical, but it had dropped in statistical level. And the cluster analysis dropped from a depression to what they call a defect. So again, that doesn't matter. From a referral point of view, I've still made my diagnosis and it's fine. But it just goes to show how difficult it must be in the secondary setting to monitor these things when a field can vary that much in 24 hours. Now, okay, once the learning process is over, it should stabilize, yes, but it still shows how difficult it must be. And within the hospital setting, they're suggesting initially at least 2 years and 6 tests are needed for an accurate measure of the rate of progression. And they're saying that in routine NHS practice is rather impractical. So because of resource limitations, especially now, of course, with delays with COVID, visual field testing is most commonly performed annually. So, it's a tough job for these people, and I wouldn't like to be there, really. I'm happy diagnosing. So what sort of therapies have we got? So ideal medical management of glaucoma. First of all, IOP reduction with all the drugs we've got available now is achieved either by reducing aqueous production or increasing aqueous outflow. The treatment aim has got to be the simplest, safest, most effective means of lowering the IOP. So the ideal glaucoma med will be highly effective, that is to say long-term use, so the patient's putting in as little as possible. It has to be well tolerated with minimal topical and importantly systemic side effects, because we're dealing with an older population base often and they might have other things going on. Simple to use, minimum inconvenience, which then will allow maximum compliance, and patently it has to be as cost effective as possible. So I'll draw your attention to this book. This is Medical Pharmacology at a Glance. I highly recommend it. It's for IP study, it just lays things out in a beautiful fashion. Right? So we've got basically 5 categories. We've got the prostaglandin analogues. They increase uveoscleral outflow, so that's an outflow. Then we've got beta blockers, which reduce aqueous production. We've got alpha agonists that also reduce aqueous production, as do carbonic anhydrase inhibitors. And then cholinergics increase trabecular outflow. So the first and last are outflow, but one via trabecular mechanism, one by the uveoscleral. And there's a little box up there. Now, let's go through them individually. Prostaglandin analogues are the first choice now. Again, back to what we were, because they're once a day, so much better compliance. And they're also really effective and also cost effective. So they increase uveoscleral outflow, and of course they're inflammatory mediators, and that's how they do it. They're opening up blood vessels, so they're opening up that whole area of flow. They've got a good efficacy, 30%, and the meta-analysis has showed that they generally are the greatest IOP lowering effect. And as I said, convenience, and no tachyphylaxis has been reported. So the side effects and contraindications of prostaglandins, And I think an awful lot of this just reflects how it works, right? They are pro-inflammatory mediators. So conjunctival hyperemia, yep, clearly inflammatory. We happen to get extra eyelashes and then increased pigmentation. Increased risk of CMO, one would expect again because it's an inflammatory mediator. Same goes with reactivation of herpes simplex if you've got inflammation going on. But then theoretical risk of inducing spontaneous abortion. Now that's a toughie. Now, you've got to look at these things. Some of them are obvious, some of them are logical to you. The CMO makes perfect sense. But what about the last one? Now you think, how bad is that? Should we really be taking that on board? Well, it's a bit like chlorphenicol. It has a theoretical risk of inducing aplastic anemia. Now, does that impact on any of us? Do we ever think that when we're giving out chlorphenicol? I mean, I don't think we do. So let's look this up. If you look up the Electronic Medicines Compendium for latanoprost, it will give you the list of expected adverse drug reactions. And they have very common, uncommon, and they have a statistical significance. So very common is 1 in 10 people will report this. So punctate keratitis, lid edema, eyelid edema, which makes sense as a pro-inflammatory mediator, iritis, again pro-inflammatory mediator, and various other things. But there's nothing there that screams out about pregnancy. Whenever you look up Electronic Medicines Compendium, it always has a section on pregnancy and fertility, every time. And in there it says, the safety of this medical product in the use of human pregnancy has not been established. Because it's not been established, they say they prefer you not to use it, right? They're not going to take any responsibility, but it's nothing there that's particularly bad. So it looks unlikely that it would cause any problems with that. But anyway, back to available preparations. Now, the one to go on to here is Medicines Complete, which is the BNF. And it'll tell you how many other drugs are available there. So we've got bimatoprost, latanoprost, and 2 others. But then it says other drugs in this class. And wow, there's a lot there. And it'll give you the combos as well. Some of the ones that are linked with other drugs as well. But I hadn't heard of a couple of these, so I looked this one up. So even though it's listed on here, simply because it's other drugs in this class, it doesn't mean it's for the eye, it doesn't mean it's for glaucoma, it's other drugs in this class. And it says this particular drug, misoprostol, is a synthetic prostaglandin analog that has anti-secretory and protective properties, promoting healing. So this is actually used for gastric and duodenal ulcers. It also acts as a potent uterine stimulant. So I think that's where the theoretical risk comes from for these prostaglandin analogs. But I think at a topic level on the eye for the glaucoma, I think just, you've got to be realistic about this stuff. And if in doubt, look it up and find out how risky it really is. So I suspect that's where the use of that drug came in. Now, beta blockers, they reduce aqueous production, 20 to 40% IOP reduction. Recommended dose is twice a day, so not quite as convenient as the prostaglandin analogs. But also 25% of individuals exhibit tachyphylaxis over time. So it's got a few little drawbacks there. Now again, back to medical pharmacology at a glance. This is how a page is set out. These are magnificent books. But they're basically the 2 beta receptors, beta 1 and beta 2. Beta 1 is for the heart, beta 2 is for the lungs. But most beta blockers for glaucoma are non-selective, so they affect both. And if you think about the sympathomimetic outcome is to increase heart rate and increase lung volume, because that's our fight or flight mechanism. And so patently beta blockers reverse those, they're antagonistic to that. So it's going to be contraindicated with people with asthma because you don't want to reduce their lung volume. And indeed, elderly, frail patients increase risk of fainting because you're going to dump or potentially drop their blood pressure. And when you think about some of these people, the only thing keeping them up is the blood pressure. So again, if you go onto the BNF, you can say these are the drugs that are in that category. and you can see how there are other drugs and the combos that are available. Then there's alpha agonists. They produce aqueous production. They apparently may also increase trabecular meshwork outflow. The only one I knew of until I did this lecture was brimonidine. That's the only one you'll find any patients in the community coming in with, putting in there regularly. But then there's this thing called aproclonidine, which they suggest is, incidentally, brimonidine is twice a day, but aproclonidine can be used as a single dose, 1%. But tachyphylaxis has been reported with long-term use. So because I didn't know what the heck that was, I decided to look it up, which again, that's what this talk's about, actually, not just lecturing you about exactly what's happening, but giving you the ideas, the tools as how to investigate things if you feel there's an issue. So I looked this up. And the Electronic Medicines Compendium, this particular drug is indicated for control or prevent post-surgical elevations in IOP after anterior segment laser surgery. So it's a very specific drug, only ever used in hospitals, and it's only associated with surgery. So again, we would never use it in the community, and it's only very much used for short-term effects or duration. So adverse drug reactions of alpha agonists, they say here, delayed type hypersensitivity to brimonidine resembles a viral follicular conjunctivitis with or without periocular contact dermatitis. Can occur many months after initially prescribing the drug. Lid retraction, and then aproclonidine does not cross the blood-brain barrier. Brimonidine does. Now, if you look at them just more closely here, just to hark back to our lectures about immunology, why does it look like a viral conjunctivitis? Well, it's because it's a type 4 delayed type hypersensitivity. And so it's cell mediated. And again, with the hapten protein combo getting passed by the antigen presenting cell and transported to the lymph nodes, and because all the processing is done in the lymph nodes, that's why it's a follicular response. So you'd have to think about that. But obviously, a viral conjunctivitis is going to last a couple of weeks and go away. This will just keep on going. Lid retraction is a predictable non-immunological effect. And then these two just reiterates the importance of those hard barriers that we mentioned in the very first talk about immunology. The carbonic anhydrase inhibitors, they also reduce aqueous production, 15 to 20% reduction. There are no reports of tachyphylaxis. When you look one up, dalzolamide I chose in Electronic Medicines Compendium. It's licensed as an adjunctive therapy to beta blockers. It's only really meant to be used as a monotherapy for patients who are unresponsive to beta blockers or in whom beta blockers are contraindicated. Now, the corneal endothelial pump does require carbonic anhydrase to maintain corneal hydration and transparency. So this is quite an important adverse drug reaction. So this really should be avoided in any patients who have compromised corneal endothelium, because we could disrupt corneal hydration. Other side effects: stinging, burning sensation. Long-term use is contraindicated, and you can get other things like pins and needles and alteration in taste and headache. But the main one is the corneal effect, the potential corneal effects if you've got a very compromised cornea to start with. So in the carbonic anhydrase, the available ones are dalzolamide and brinzolamide, and of course Diamox. So when you look them up again, there's other drugs in the family. I will draw your attention to this one, Simbrinza. In a few slides' time, we'll go through combos, but this is the first one. Every combination drop up until this was a particular drug with timolol. So it was always with the beta blocker. So you might have a prostaglandin analog with timolol. You might have a carbonic anhydrase inhibitor with timolol. This is the first time there's not. This is an alpha agonist coupled to a carbonic anhydrase inhibitor, Simbrinza. So that's just something to be aware of when you're studying. So the miotics, though, they increase aqueous outflow, very old drugs, and they do have a significant IOP reduction. They have a good safety record, but they're 4 times a day, so they're very inconvenient. Visual disturbances caused by significant pupil miosis. They have very common headaches with ciliary spasm, so they're no longer routinely used. And in fact, if you look up the BNF, their use is unlicensed. So obviously, ophthalmologists, consultants can prescribe it, but it is an unlicensed use now. And the only other drug in the family is actually acetylcholine. So fixed dose combination therapies are where you've got 2 therapeutic agents in the one bottle. Now, this author suggests that they can be synergistic, and by that she means they have the same mechanism of action, so they may both produce or increase aqueous outflow, or they could be antagonistic, where they have different mechanisms of action. So one might reduce aqueous production, while the other one increases aqueous outflow. Now, before I come back to that statement, I'll say the next statement. These are typically, FDCs are typically as efficacious as the same components given concurrently. So what that means is they don't dilute each other. The effect together is not reduced, but nor is it improved. It's just the same as if you took the 2 drops individually at the same time. So going back to this first, I'm sorry, I simply can't agree with this statement. A synergistic effect is where the clinical outcome is effectively greater than the sum of the 2 parts. So you have the 2 new drugs and their outcome is actually a better result than if you use each drug individually. That's what synergy means. An antagonistic mechanism is where they actually counter each other and effectively make it worse. A classic example would be putting pilocarpine in the eye as well as cyclopentolate. One's trying to reduce the pupil, one's trying to increase it, and they are antagonistic mechanisms. So I'm afraid, to use the terms correctly, you cannot state that. They may have the same mechanisms of action or different mechanisms of action, but they are neither synergistic nor antagonistic in effect, in medical effect. But anyway, either way, the FDCs certainly should improve adherence because they're in a single bottle compared with the same medications used concurrently. Here's a list of the ones that are, some of the ones that are available. And as I've said earlier, if you notice that they're virtually all combined with timolol, apart from Simbrinza, which is the newest kid on the block, and as I said, has a carbonic anhydrase and an alpha agonist. Now down there, you'll also show what sort of preservative they have, and you'll see that most of them have back, of course, and some of them are also available as preservative free. Now this is worth a bit of a comment. Again, linking back to our immunology and allergy, I think that back normally, if it was causing trouble, you're going to see a toxicogenic reaction. So you're going to see microtrauma of the cornea, epitheliopathy, desiccation. The patient will have an irritable, gritty eye, but the lids will probably be fine. Far less likely for preservatives is a type 4 allergic reaction. In this case, you would not necessarily expect the cornea to show any microtrauma. It would simply, well, it would be clear and the lid might be bad. So if it was something like this, you'd probably be more suspicious that it was actually the active therapeutic ingredient in the drop rather than the preservative. Just a thought anyway. But anyway, anything used more, any drop with preservative more than, as we all know, used more than 4 times a day is likely to cause some sort of reaction. And if we find that reaction, then we'd arguably ask for preservative-free. But it's never the first line drug, of course, because they are significantly more expensive. Then they go through guidance that state about generic versus branded drugs. And I mean, why? So a drug retains its brand name. For instance, Zalatan is the one that I always think of, while under patent protection. And it has a name that's not actually the chemical compound. The chemical compound is latanoprost. But once the patent expires, other manufacturers can make the medication as a generic. So why? Well, the biggest one's cost. And you think, well, why doesn't the branded one, why isn't it cheap? Well, you know, they've got to recoup. It's not unfair because they've got to recoup a huge level of research and development that's gone into that original drug. So they have every right to expect, as it were, a cornered market for some time while they recoup the huge cost where they weren't making any money from sales because they were developing the drug, and that can take years. But once it's unbranded, the primary risk with generics is, are they as effective? Because there's no stringent R&D evidence for them, whereas the other lot had to go through the whole rigmarole of doing that. So they state that generics must be manufactured using the same standards and good manufacturing practices required for the branded products. Generics must have the same active and inactive components. They can't muddle up. You can't just have latanoprost. You've got to have the whole lot. And if there isn't, then they have to do a study to demonstrate bioequivalence. But you'll notice that everything states first line treatment. They don't just say prostaglandin, they say generic prostaglandin, because from a costing point of view, it's critically important. So we also could talk about compliance with our patients in the community. So up to 50% of glaucoma patients are non-compliant apparently. Now you think, at what point do you call it non-compliant? You know, most contact lens patients will admit that they've slept in their lens at least once. So, you know, non-compliance might be that they went away on a long flight and missed one drop. But all the same, what are the potential barriers, and do we indeed have a role out there in the community? So if they're using multiple drops, it's important to ensure that they wait 5 minutes between instilling the second drop. Patients might get into the habit of thinking, oh crikey, I'll just put them both in now and get on with it. And certainly you don't want the first drop to be diluted by the second. And if the IOP is at target, is it important to encourage them to continue it? You know, positive reinforcement, not just negative, and say, wow, this is really great. Your pressures are down where we want them. They're looking good. They're well within the normal range. Keep doing what you're doing. But if it's not at target, then take the time to think, well, are you doing it properly before you start saying, oh, crikey, we've got to send the patient back. You know, make sure they're doing it properly. The installation techniques, if it hasn't been reduced enough to guarantee prevention of sight loss in their lives. And then there's this website at the bottom, guidelines or guidance on instilling eye drops, and it can be accessed from that particular website from the NHS. So, but back to IP in the community for a minute. Just say some extreme circumstance forces you, in the patient's best interest, to treat in the community. Now, this does happen. I mean, the very first time it happened to me, the patient said, I'm not going. So in the letter I referred to the hospital, I said, I do not believe this gentleman will turn up. If he does not turn up, please let me know. And the doctor wrote back sometime later and said, yep, didn't turn up. And so I started treating him. Now, ethically, the NICE guidelines say that's not appropriate, but you could just annotate the note, say, I did my best, legally I'm free, but is it in the patient's best interest, and is it really ethically the right thing to do? So if you do decide to treat in the community, what is your default clinical management plan? Well, again, the best place to start really is the BNF. because in the BNF it has this little area that synopsizes everything, and it basically says topical prostaglandin analogues such as those are used first line in patients with confirmed COAG. And then it tells you what to do if these fail and what to add. So it's a very neat little way of just quickly looking it up without going into textbooks or whatever, and finding out what to do. So again, a good resource. But the NICE guidelines also stipulated in a way that, again, first line generic PGA. And then if non-tolerant, you'll go through these different processes as well to try to improve it. So NICE also give you advice on how often you should be monitoring patients. Now, patently, this is geared more for hospital-based clinicians, ophthalmologists and optometrists within the hospital. But just say you were put in that awkward situation where, that extreme situation where you did feel for the patient's best interest, you did need to treat in the community, then it gives you guidelines on how often you should be monitoring these people until you're very, very confident there's no progression, and then you can follow it on from there. But then they go on to treatment of OHT. And this is a different animal because these patients don't have glaucoma. So if the pressure is higher than 24 millimeters, we want to start treating with prostaglandin analog if they are at risk of visual impairment in their lifetime. Tricky call that, isn't it? And do not offer treatment to patients with OHT who are not at risk of visual impairment in their lifetime. And that's where it becomes very, very tricky. So how do you refer on an intent to treat basis? Because I think this is what, as IPs, we should be doing. So for instance, here's an example. You've done your thorough case history. The general health is excellent. There's no medical red flags. There's no family ocular history. You take tonometry with GAT, it's 26 millimeters of mercury. You repeat it and you confirm it. Their pachymetry is 590 microns. Van Herrick's wide open. Anterior chamber, no signs of secondary etiologies. The optic nerve head is absolutely spot on. And therefore, obviously, the thresholding fields are absolutely full. So, are you going to refer that? The pressures are greater than 25. Then you've got to think about the level of IOP, the CCT, family history, life expectancy. So would you refer or monitor that patient? Now, maybe this doesn't constitute a clinical dilemma to you, because if you're doing one of those GAT refinement services, there's 25 millimeters of mercury, refer. But we all know now how variable all tonometers are. So what if they get to the hospital and they measure at 24, which is highly likely or highly possible, then suddenly it gets bounced back. You've wasted the patient's time. And it is true, how many do get bounced back? And you think, wow. And sometimes only to find out later they've converted. And you think, well, I wish they'd started in the first place. So I rather liked the 2009 NICE guidelines on treating ocular hypertension, because it had a lovely little algorithm, and they gave you a very nice little table, which you can see here, which told you what sort of, on the risk basis of age and so on, as we've already seen, what's the biggest risk factor? CCT. Then the next down the list is IOP, and then age. So it's taken those risk factors and put them together rather nicely, and it shows you even up pressures right up to 32. If the CCT is more than 509, they're not going to treat anybody. Then you've still got this treatment between 555 and 590 up to 25 millimeters of mercury. Again, they're not going to treat. Then after that, they start treating. So since the way we responded, where we're referring everyone with pressures of 22, the NICE decided to up the game a little bit, and they increased the cutoff point to 25. Now, of course, this improves specificity of referral, but arguably at a cost to sensitivity. But has it really? Let's have a look. If you take out the 25s, you're taking out a whole group there with thick corneas. You weren't going to treat them anyway. And indeed, the same thing goes for 555 to 590. The only group that are coming a little bit unstuck in a treatment regime is the group up until 65 with CCTs less than 555. So even then, it's not a bad thing, because it means that we might decide in the community, okay, we're not going to refer that patient because they've only got pressures of 24, but because their cornea is quite thin, we may choose to monitor them more frequently. So it really does help us coordinate our management of these patients in the community until they perhaps fall into a prophylactic treatment category or morph across to be frank glaucoma. So I certainly still use this scheme very much in my practice. And if you are going to monitor in the community, how are you going to do it? Well, again, the NICE do give you some review schedules. So if the pressures are 26, say, but you've decided to monitor yourself, you might think, well, I'm going to increase the review rate so that I can see and I can refer this person if they convert. And I think that that's a clinician's work, and I think there's nothing wrong with doing that. Some people won't be as comfortable with it. I am comfortable with it, but your review rate has to reflect your risk levels. So surgical managements of glaucoma now, we've got basically 4: trabeculectomy, shunt surgery, laser trabeculoplasty, and these MIG things. So first, trabeculectomy, standard surgery for glaucoma, small hole made in the wall of the eye, flap is created over the hole, and fluid is shunted into that hole and gets absorbed into the systemic circulation. But recovery time's up to 6 weeks, and they have to use anti-scarring meds, so it is invasive surgery for sure. And then, of course, like all surgery, it has some relatively serious potential complications, endophthalmitis, intraocular hemorrhage, loss of vision, and so on. So tube shunt surgery, it's a valve, it's shaped like a small mouse, really, PC mouse in a way, and the plate portion of it sits on the surface of the eyeball under the conjunctiva. Because it's silicon, it's biologically inert, and so it won't be rejected, and also it's covered by your own tissue anyway. The intraocular fluid is collected and into there, and then goes into the general circulation via the ocular veins. And the procedure is done as an outpatient procedure, so it's quite quick and easy. They've been successful in fairly difficult glaucomas, such as neovascular uveitic glaucomas and so on. So quite a neat little thing. Then there's these minimally invasive glaucoma surgeries, MIGs. This is new and exciting prospect in the treatment of glaucomas. They can be done while you're having cataract surgery. I think the jury's out on these yet. I think they're still being tested, but they certainly seem quite positive. And then there's laser trabeculoplasty. So it's used for several types of open-angle glaucoma. But a laser is, what I love about this is they don't really understand the mechanism, you know. So you're taking a hot laser, and basically laser energy is converted into thermal. It contracts the trabecular meshwork. The tissue contraction and scar formation result in mechanical stretching of the TM and improves our aqueous outflow. You think, wow, you know, who the hell thought of doing this? I don't really know how it works. You think, could I be scarring it up and making it worse? But it seems to work. And it does induce a subsequent reduction in IOP. But there's also now selective laser trabeculoplasty. With ULT, 2 years after ULT, the pressure from glaucoma increases again, and you can't repeat the process. SLT, it's lower energy. It achieves the same result as ALT, but the main benefit of it is it allows it to be repeated 4 or 5 times with similar success rates to ALT. So it's becoming the one. Indeed, SLT appears to be less destructive histopathologically, and the potential of beneficial of repeatability of the procedure. And this paper in the Lancet, and if you get published in the Lancet, you're pretty good. They're suggesting that SLT should be offered as a first-line treatment for open-angle glaucoma, and therefore they're supporting that it could be a change in clinical practice. So, glaucoma used to be very much a surgical specialty because meds just didn't work very well. Now it's become fundamentally a medical specialty, and if this was the case, it could go back to being surgical. So my final observation is, this is written out of NICE. The recommendations in this guideline represent the view of NICE, arrived at after careful consideration of the evidence available. When exercising their judgment, professionals and practitioners are expected to take this guidance fully into account, alongside the individual needs, preferences and values of their patients or the people using the service. It is not mandatory to apply the recommendations, and the guideline does not override the responsibility to make decisions appropriate to the circumstances of the individual, in consultation with them and their families and carers. So again, despite all the idealized guidelines, NICE state, this was in the 2009 one, while guidelines assist the practice of healthcare professionals, they do not replace their knowledge and skills. So as IPers, we need to think flexibly and always consider patient needs. Exceptional circumstances will appear, and currently there are significant numbers of patients in a severely delayed system wanting advice and help within the community. So I think we are important parts of this group, and I think we have a major role to play in all of it. Thank you very much for listening.